Okay. Good morning. Thank you, Beth and Tanette, for inviting me and putting this all together again. So I'm going to talk to you about the transcatheter aortic valve replacement, or the TAVR. Okay, so the TAVR is an aortic valve replacement that's done through a catheter approach. There are several access points. Most of the procedures can actually be done percutaneous femoral, but we also have the option of femoral cut down, subclavian access, a direct aortic, or transapical. It's something that's done under MAC or general anesthesia. Generally, most of our percutaneous cases can be done under MAC, which is great because then we can avoid intubating the patient. But certainly the cut downs and more invasive approaches, we do have to use general anesthesia. So the native aortic valve remains and is displaced by the new valve implant. Once in place, the new prosthetic valve begins to function, and it's indicated for use in those with severe symptomatic aortic stenosis that's due to a degenerative calcification of the valve. So what is the etiology of this? The mechanisms of stenosis are similar to atherosclerosis. There's mainly solid calcium deposits within the valve cusps, and this causes a progressive calcification and thickening of the leaflets, so they become stiff, they don't open, easily or fully. It's similar to risk factors that contribute to coronary artery disease. There's a very high coincidence of those with coronary artery disease as well as aortic stenosis, and it generally occurs in the 6th, 7th, and 8th decades of life. So a normal aortic valve opening should be 3 to 4 centimeters squared. It's considered to be severe when it's opening less than 1 centimeter squared. And if it's opening less than 0.7 centimeters squared, this is considered to be critical aortic stenosis. So what is the prevalence? It's actually the most prevalent native valve disease. 2% of those over 65, 3% over 75, and 4% of those over 85 have this disease. And we are diagnosing over 100,000 people with this every year in the United States. So what are the symptoms? The classic symptoms are angina, syncope, and heart failure. But it's the heart failure and dyspnea is what, once they have those types of symptoms, this is what foretells the worst outlook in the patients. And if you see the survival curve here, you have this latent period, and then once they have the onset of those heart failure symptoms, you see this rapid decline in survival. So what was the rationale for developing this procedure? Surgical aortic valve replacement was the gold standard treatment, reduces symptoms, improves survival. However, more than 30% of people with the disease were not being treated for it. And the reason is because they were a high or prohibitive risk for surgery. So as I showed with that last slide in the survival curve, mortality is about 50% within 1 to 2 years once symptoms present. So developing a minimally invasive procedure to treat these patients has been an amazing, alternative. So TAVR for extreme risk. These are people that are inoperable. These are people that their mortality risk with surgery is at or greater than 15%. There were 2 trials done. The Partner 1B, this was the trial with the Edwards Sapien valve. It was completed and FDA approved in November 2011. And then there was the Core Valve US pivotal trial, which was completed and got FDA approval in January 2014. We participated in all of the Core Valve studies here at Sinai. So basically what these studies showed is that when you looked at the TAVR in patients versus optimal medical therapy, there was a significant improvement in mortality when you treated them with the TAVR versus just medication or perhaps a balloon valvuloplasty. TAVR for high-risk cases. So these are people whose mortality risk with surgery is 10 to 15%. Again, 2 studies, Partner 1A with the Sapien device. This was completed and FDA approved May 2012. And the Core Valve pivotal study, which was completed and we got approval June 2014. So ultimately, whenever you have a new device or a new procedure, you always need to prove that it's at least non-inferior to what the gold standard is. So that is indeed what Partner 1A showed. The TAVR was non-inferior to surgery. So both of these studies were 1-to-1 randomization. So basically 50% of the patients had surgery to correct the problem, 50% had TAVR. So the Partner 1A showed that the TAVR was non-inferior to surgical valve replacement in high-risk patients. The Core Valve pivotal study was the first transcatheter heart valve study that actually showed superiority of the TAVR to surgical valve replacement in high-risk patients when they looked looked at all-cause mortality and cardiovascular mortality. And we actually implanted the first core valve in the country. So, the TAVR for intermediate risk patients. So these are people with a surgical risk 3 to 8%. Again, 2 trials, the PARTNER 2A with the Sapien device. This has been completed, and we do have FDA approval, August 2016, so that commercially we can do the TAVR in patients that are intermediate risk with the Sapien device. The SURTAVI trial was with the core valve. The study is completed. There is a continued access study going on. However, we have not gotten approval yet. We're waiting for the data to come out. The hope is in the next month we will have approval for this in intermediate risk patients. And again, that was a 1-to-1 study. 50% had surgery, 50% had TAVR. So TAVR for low risk. So this is the question. These are people who have a surgical risk that's less than 3%. 2 trials in the US that are ongoing, the PARTNER with the Sapien and the Evolute R, the core valve, which we are participating in here. We've actually enrolled and done 15 patients at this point. So again, a 1-to-1 randomization, 50% have TAVR, 50% have surgery. You know, one of the biggest concerns here in this risk population is that, you know, we know the lifespan of a surgical valve. We know that, you know, for the most part, a surgical valve is going to live about 15 years. We can't answer that with TAVR at this point. And so there is some concern that, you know, in your 60-year-old patient that you're going to do a TAVR in, and what if the valve only lasts 8 years? Okay, after 8 years, you could do a valve in valve, but then what happens if that degenerates? Because we still haven't answered that question. I mean, we're all hopeful that, yes, the TAVR valve is going to last as long as a surgical valve, especially with our newer generation devices. But we don't know that answer yet. So these, you know, this remains to be seen. Okay, so what are the benefits of the TAVR? And we know this from all the studies that I just spoke about. You have a reduction in all-cause mortality, cardiovascular mortality, and repeat hospitalizations. You have improvement in their gradient and valve area, their heart failure symptoms, their walk test, and most important, of course, is their quality of life. What are the adverse events? You know, any procedure comes, you know, with complications that can happen. I know Dr. Sharma brought up earlier, but so stroke. This is one of the big concern. You're manipulating and implanting a valve within a calcified aortic valve. So there's always concern debris, calcium can come off and contribute to a stroke. The risk of stroke has gone down dramatically with this procedure. You know, initially there was more stroke in TAVR versus surgery, and that is no longer the case. The stroke rate has gone down to about 2% with TAVR, and it's about 4% with surgery. Valve dysfunction or paravalvular leak. So what this is a leaking that occurs around the valve. So, you know, you're implanting a valve within a native valve that has calcium chunks, and it's not a perfect circle. And so, you know, if the device or if the valve doesn't seal well in a certain area, you end up having leaking around it. This is significant if it's severe because it does correlate with an increase in mortality. So, you know, this can happen, like I said, from masses of calcium. It can also happen if it's malpositioned. So if the valve is too low or too high, you know, that can contribute to this. Conduction disturbance, you know, this is the design of the device where it sits in the outflow tract that you can end up having a patient need a pacemaker. Of course, vascular and bleeding complications, you're going through an artery. Annular rupture, back to those calcium masses I talked about. You know, calcium's not some soft, squishy thing. You know, it's hard as a rock. So, you know, if you're going in with a balloon and a valve, you're always concerned that a mass of calcium can rupture the annulus, which really would be a devastating event. LV perforation, you have a stiff wire in the ventricle. Somebody needs to be watching the wire because you can end up with tamponade and urgent need for surgery. Acute MI, it's rare, but you know, when we do the CAT scan, we really have to pay attention to the distance of the coronary ostia to the annulus, because when you implant the valve and you slam those native leaflets up, you have to, you know, could you potentially occlude the coronaries? Thrombosis, this is actually a hot, you know, talk right now because there was a recent study that came out, and it's a small study, but they are seeing thrombosis development on TAVR leaflets. And they're seeing it more in balloon expandable valves, but this is a concern because we still don't have the answer to the question on what's best in these patients in terms of antiplatelet versus anticoagulation. So right now, generally we do dual antiplatelet therapy, aspirin and Plavix, but there is an ongoing study, the Galileo study, which we're participating in at Sinai, where we're looking at aspirin and Plavix versus aspirin and Xarelto, and what really might be best, because thrombosis, now you're concerned about stroke if that's happening, and you're also concerned that it's going to degenerate the valve, right? So this is something we really need to look at. Infection, of course, anything invasive, and death. So these are the Medtronic core valves. There have been 3 generations at this point. Just in general, they're all a nitinol frame. They're all porcine pericardial tissue. They're all self-expanding valves. This is the core valve classic that was in the pivotal study. Came with an 18 French sheath or delivery system. This is the Evolut R, the 2nd generation. This actually went down to a 14 French sheath, so reducing vascular and bleeding complications. I'm going to talk in the next slide about the other advantage of this new generation, valve, and then also this is the Pro. So this is the 3rd generation and the latest approved valve that we're using now. This, you can see, has this external wrap here, and that is to create a better seal and prevent that paravalvular leaking that I talked about that's a concern. The other nice thing about the Evolut and the Pro is that they're recapturable. So there is a point of no return. However, you can expand the valve to this degree. You can do an aortogram, and if your valve is too deep, if your valve is too high, you can actually fully recapture it, reposition, and get yourself into a better position. And this has implications, like I said, paravalvular leak if you're not well positioned. Also, if the valve is implanted too deep, you increase the risk of conduction disturbance. So this has been a great advantage of this. What I will say, going back to the Pro just quickly, is that, the one thing is as we advance, you have to be cautious, sometimes you advance, but yet other complications might increase, or there might be certain fallbacks. So the Evolut R was a 14 French sheath, the Pro is 16. So it actually did go up a little bit because of the wrap, so these are the Sapien devices. This is the 1st generation Sapien. This was a stainless steel frame. This is the XT, the 2nd generation, which is a chromium cobalt for better apposition. Both are bovine pericardial tissue. These are balloon expandable valves. The 1st generation Edwards was a 22 or 24 French delivery system. Very, very large. The XT was 18. So we really reduced the vascular and bleeding complications going down like that with the delivery system. This is the Sapien III. This is the 3rd generation Sapien device that's approved. It's still chromium cobalt, but thinner struts for better apposition and better endothelialization. It's still bovine pericardial tissue and balloon expandable. You can see they added an outer skirt, and this is to have a better seal and prevent the paravalvular leak. It's a 14 French sheath, so they did go down with that, so reduce bleeding and vascular complications. And again, what I had just said with the Pro, with this, we've seen an increase in the need for pacemaker in this newer generation Edwards because of this outer skirt and the way it can affect the bundle branches. So the Sentinel cerebral protection device, we just got FDA approval on June 5th for this device. We participated in the study at Sinai, and then it was closed for about a year, and the device just got approval. So this is a cerebral protection device to help prevent periprocedural stroke. There are 2 filters. One sits in the right brachiocephalic, one sits in the left common carotid. And basically, this is put in before any pre-BAV, the TAVR implant, the post-BAV. And ultimately, any debris or calcium that comes off during the procedure is going to be captured by these filters. And then it goes in through the radial artery. It's a small catheter, and then at the end of the day it comes out, and we are certainly finding things in these filters. We actually did one on Monday, and we did one yesterday for the live symposium, and they took pictures of the filter. Okay, so how do we evaluate these patients? So first and foremost, of course, they have to have severe aortic stenosis, and we do that through an echo. Valve area less than 1 and other gradients we look at. With the CTA, which I mentioned earlier, perhaps one of the most important tests we do for these patients in the workup. What size is their annulus? What size valve do we need to put in? What is their access going to be? Are there anatomical contraindications or concerns? Cardiac catheterization, they have PFTs and carotid Dopplers. We assess their heart association functional class. This procedure is indicated for those with class 2 or greater symptoms. And they have a consult with one of the interventional cardiologists on the TAVR team. The next important thing is the surgical risk assessment, right? Because like I said, this is approved for certain risk populations. So we have specific surgeons on our team that see the patient and consult with them. And the way they determine the surgical risk is 2 things. They use an STS risk calculator. It's basically, you go on and you put in certain demographics and medical history, and it basically spits out what their mortality risk is with surgery. The problem is it's not all encompassing. And so there are also incremental risk factors that the surgeon has to consider that might not be accounted for in the STS score. So just frailty, for instance. I mean, that has huge implications on how someone's going to do a surgery, but that's not included in the STS risk calculator. So here's my case study. This is YK, an 86-year-old guy. He's got class 3 heart failure symptoms, history of AFib, coronary disease with a PCI, TIA, pulmonary emboli, pulmonary hypertension, anemia, osteoarthritis, and a seizure disorder. You can see the meds he's on. His echo showed actually critical AS. His valve area was 0.6. EKG was sinus. He had his cath. He did have 1 vessel disease. We did a PCI. Any patient that does have a PCI will wait 30 days before we go ahead and do the TAVR. We did all of the diagnostics that I spoke about earlier. His STS risk came out to be 4.6. So this would actually fall into the intermediate risk, right? 3 to 8%. However, when the surgeon saw him, given his advanced age, he's frail, his anemia, the pulmonary hypertension, all considered, he was actually determined to be high risk for surgery. So the plan was for a 31 millimeter core valve. He had great size vessels, so we could do it percutaneously, which also meant that we could do it under MAC without general anesthesia. This is a quick picture of what they're looking at on the echo, and this is how they measure the gradients. This is a look at the CT, and this is how we measure the annulus. So just take note of these white masses here. Those are those calcium masses I talked about. This is us measuring that coronary ostia height. I mentioned earlier, we're concerned the native leaflet could include when you implant the valve. Once you're at 10 millimeters or less is when you're concerned. He's in the clear, obviously, with 13 and 15 millimeter distance. And this is how we're looking at our access in the common femorals. And he had great size vessels, 9 millimeters. This is another image of the CAT scan. It's a 3D image, and this really helps us with being able to look at other challenges that might be there, like tortuosity, aneurysmal areas, different things like that. And it's pretty. All right, so this is his case. This is us with our valve in place, not expanded yet, of course. Here we are releasing our core valve. Okay, so here's our valve in place, and we're using the pigtail to do our aortogram. So he's got a severe paravalvular leak right now, okay? And we don't like that because, like I said, it correlates with mortality. I mean, we don't want to fix the AS and create severe AI, right? So what do we do when this happens? Well, we can go up with a balloon, and you can try to, better oppose the valve, okay, and get a better seal with this. So this is what we did with a 28 millimeter balloon, and then this is our post picture. There's still paravalvular leak. However, we brought it from severe to moderate. So at this point, there's a lot of discussion. Should we go up again with another balloon and try to get this to, mild or mild to moderate? But remember the masses of calcium, and remember the risk of annular rupture. So we need to be judicious with this. And so at the end of the day, the hemodynamics were great. We said, we're happy with this. We don't want to cause a devastating event. And he actually did great. He went home the next day. We've seen him for follow-up, and he's done really, really well. So growth in TAVR at Mount Sinai, I mean, you can see our trend here from 2011 to 2016. I mean, it's just continuing to increase. We went up almost 40% from 2015 to 16, and I can absolutely guarantee you we'll be well over 300 cases this year. So again, excellent volume and also outcomes. So we're in yellow and the TVT registry is in blue. The TVT registry is, all the commercial cases, all of this data gets inputted. So complications, all of that kind of thing. When we look at our complication rates in comparison to the national rates, in every category, our complication rates are lower. When it's in-house mortality, 30-day mortality, CVA, valve-in-valve, vascular complications, and pacemaker. So going forward in TAVR, we're always striving to improve outcomes. You do this with a well-established TAVR team, good patient selection criteria, the improvement in operator skills that have come with time, the improvement in valve sizing and positioning, judicious use of the post-implant dilation, all of these subsequent devices and, the reduction in sheath sizes that have come, the distal protection device, that beautiful Sentinel device that just got approved. We need better standardization of the antiplatelet and anticoagulation that I brought up, and having really well-established pre- and post-procedure protocols is vital. So in conclusion, the TAVR is an alternative treatment for aortic stenosis and those that have at least an intermediate surgical risk. The results of PARTNER 3 and the Evolute low-risk studies may result in a paradigm shift in how we manage low-risk patients. It results in marked improvement in valvular function and yields immediate, clinical and hemodynamic improvement. And the results of the diagnostic workup, the surgical risk assessment, this is how we determine if it's the right course of treatment for the patient. And I thank you so much.